Yes, good morning.
Okay. I am Dr. Abhishek, one of the child doctor working in this hospital. I believe I am talking with Stephen and his mother Kate.
Yes, doctor, yes.
Actually, I have received a letter from the GP regarding um, Stephen's poor sugar control in recent times. So I would like to ask you a few questions regarding this. So is it the suitable time for you?
Yes, doctor, please, you can.
Hello, Stephen. How are you?
I'm fine, doctor, as of now.
Okay. So, can you tell me what might be the what might be the cause that your sugar control is recently very poor? Do you have any idea about it?
How can I tell the doctor? I really don't know why this is happening to me. And I was just trying to control my blood sugar, and everything is fine. With this controlling all the diet, I was as well, and doing exercise nowadays, and going to gym as well. But
Okay.
again, blood report is not so much of good. Why this is happening to me, doctor? I really don't know.
There are some several background noises. Sorry.
Can you hear me now? Now, is it clear?
Yes. Just once.
Okay.
My headphone
Pause.
is not working. Hello.
Yes.
Hello.
Yes. Hello. Are you ready?
Okay. Yes.
Continue.
So,
Continue, please.
okay. So, did you notice any did you notice any change in your vision, or did you any dot and lines in your eyes or flashes of lights in your front of your eyes?
No, doctor. Nothing is there. Such thing.
Okay. Or is there any change in peeing?
No, as usual. I can't say, doctor. Sometimes in the night I need to wake up for pee. That's
Okay.
irregularly. I need to go frequently, not in a regular basis.
Okay. Is there any pain or any burning during peeing?
Sorry. Oh, in the pee. No,
In,
no, no
yes.
such thing. No.
Okay. Actually, did you notice any episode of any sweatiness, or you get some hungers or racing of hearts?
Actually, I have hunger, but I used to control my diet because
Okay.
dietitian have some restriction. Yeah,
Yes.
restriction of diet on me, so that's why I'm trying to follow all this.
Okay. So, did you find any unusual sensation or any numbness in your hands or legs or feet?
No, no, nothing. No.
Okay. So, can you tell me since when you have noticed this, your sugar is not well controlled?
I don't know, doctor. Previously, that was well controlled, but nowadays I am really unaware of the fact that how this is, just happening with me.
Okay, so do you have any a diary? Do you have any sugar diary or any ketone diaries with you?
Yes, doctor. Yes, I have. I have.
So uh, can you show me that? Is there any episode of high sugar or any ketones?
Ketones is not there, but the sugar is not in normal range, doctor. Whatever the doctor said, I need to keep the sugar within this limit. But
Okay,
especially in the evening time, and maybe sometimes in the morning time, after doing so much of exercise, as well as controlling blood, the diet. But the blood sugar is
okay,
not going down.
okay. I can understand your concern. So do you have any recent change in your diet?
No, doctor, no. I'm very strict with my diet, doctor.
Okay. So did you ever take any lot of sweets or any snacks outside home or party?
No, 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 doctor. I am very much concerned about my diet. So I know I have diabetes. So
Okay,
I never.
okay. Did you take your insulin regularly? Is there any episode there where you forget to take any insulin?
Yeah, it's one or two occasions what I remember, but that not significant enough, doctor. I can't remember that, but there is no chance that I have missed.
Okay, so did you take insulin during school time also?
Yeah, doctor, I am very much particular. So the school nurse is also helping me whenever there
Okay,
is a time, and sometimes she used to remember. I mean, she used to just ask me that I'm taking it regularly or not. Even some guidance is there, and she is helping me out. So there is no chance.
okay. So can you tell me, did you change the height of taking insulin in your body, in your tummy or in your legs? Did you change the sides?
Yeah, doctor, because the diabetic nurse told me that I need to change the sites. I mean, site means the area. So I am regularly, giving different areas, not in particular area.
Okay. So do you notice any there is any skin color change while you take insulin?
No, no, no such thing. No.
Okay. Do you perform do exercise daily?
Yeah, nowadays I'm doing this daily, but for last, I mean, 15 days near about,
Okay.
because my blood sugar is very fluctuating nowadays. I can see that, whenever I'm testing at home.
Okay. I'm sorry to hear that. Um. So did you have any recent any episodes of any fever or any uh infection in your ears or any ear discharge from ears or any cough and cold or anything?
No, no, doctor.
Okay. And is there any episode of any pain in your muscles or any joint pains? Did you notice?
No, no, doctor.
Okay. And any episode of any racing of heart or any swelling of feet?
No. Okay, sorry. So sometimes what happens, I can feel that sometimes my heart is racing, whenever I
Okay.
am just sleeping, or maybe in early morning, I can feel that yes, my heart is beating a little bit of fast. Yeah, that can I
Okay.
feel, doctor, and that's
Okay.
why
So
sometimes
what?
I'm very much sweaty.
Okay. So what you do at that moment?
So it's nothing, doctor. Basically, it's nothing. Uh, I'm not doing anything special for this.
Okay. So did you take any? Did you check the blood sugar level right then, or take any glucose at the time, or did you do anything?
Yeah, a few occasions I checked my blood sugar. At the time that was normal, but most of the time nowadays it's fluctuating.
Okay. So as you told me earlier, but can you say is your sugar level is normal at the night times?
It's near about higher side, not in a normal.
During night it is also higher.
Yeah, yeah.
Okay. So can you tell me what about this your appetite and your poo habit? Can you tell me about that?
Yeah, there is sometimes I can feel there is some loose poo, and not really hard poo. It's very rare occasion, but I can notice. I have noticed that sometimes it goes like watery, you know, and I
Okay,
am
sometimes.
losing so much of weight nowadays.
Okay. And
9 minutes up. Huh?
Okay. Oh, okay. Sorry. And do you have noticed any? Is there any swelling in your neck or anything?
No, I don't have any swelling, doctor. No.
Okay. So do you able to tolerate heat or cold? Any problems?
Yeah, nowadays what I can feel that whenever I'm going to school, especially in a sunny day, so I can feel a little bit of more, you know, the sweaty.
Okay.
It's
Okay.
like
And
I'm feeling very hot. I mean, this heat is basically creating some problem.
okay. So do you think any so tell me about when you were diagnosed with the uh, diabetes from at the age of 6 years back. So how you diagnosed?
Yeah, that time I need to admit it, doctor, because at that time there was so much of severe blood sugar high. I got just unconscious and I need to admit in the ICU. And the doctor said that I have got this diabetic ketoacidosis, and the treatment went through at the time. And after a few days, they got discharged, and I have been diagnosed with diabetes. So after
Okay.
that, we injected in this insulin.
So what are the investigations done at that time?
Yeah, these investigations basically what I can remember this hemoglobin A1C, blood gases, chest X-ray, urine, and
Okay.
many investigation has been done at the
Any
time.
other special test and doctor mentioned about anything other than this diabetes?
No, at that time nothing was there.
Okay. And who are involved in your follow-up? Who are the what are the defined doctors, staffs like dietitian or anything they are involved in your follow-ups?
It's the diabetic nurse. I'm following up the special data. I mean, the diabetic doctor and some social worker and
Okay.
yes, and a few
So
more I
can you
can't
tell?
remember. Yeah.
Okay. So tell me about your height and weight. Do you have your red book along with you
Yeah,
about your
yeah.
growth?
Height and weight according to the rate that is, I have my growth chart basically, so everything is fine over there. Doctor said.
Okay. And do you have many child of your age has entered puberty? So do you have any changes like develop hairs in your armpits or in your private parts?
Yes, yes, doctor. That's developing and just having my signs of puberty. Yes.
So did you bring your jab? Did you take all the jabs?
Yes, yes, it's over. I mean, just 15 years of age maximum. Jabs, the immunizations it like covered.
Okay. Any extra jabs you have taken?
Extra like.
Like pneumonia and flu vaccines, flu shot.
I have completed all these things too.
Okay. And do you have any allergy to any medicine or drug?
No, 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 doctor.
So let me ask you about about confirmation about your home condition, finance and support. So any problem I can help you out. So who are living in the house?
So it's me, my elder sister, and my mom and my dad.
Okay. And do you attend school regularly?
Yes, yes. There's no problem. I'm going to school. There's no absence.
Okay. And is there everything is okay in school? Is there any kind of bullying or anything?
And initially there was some bullying with the teacher. They are, just making fun of my injections. So after going through the school nurses. I have just spoken to the teachers, and after that they stopped. Basically, nowadays there is no bullying.
Okay, sorry to hear that. And so is there any kind of stress in your school, in your home, or anything you are worried about?
No, doctor.
Pardon me for asking this. So I can ask you some personal questions.
Yes, please. Your time is
Uh,
over.
okay.
You can ask.
So,
Okay, complete another 1 minute, please. I will
okay.
just complete.
So did you take any kind of many children of your age take some smoke or sometimes drink or take
No, no,
some
doctor. No, 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 no,
any kind of drugs?
no, doctor. No.
Okay. And uh, is is there anything you want to tell me more? We have not covered yet.
No, I think I have told everything.
Okay. I just summarize.
Yes, summarize, please.
This a 15 years old Stephen have a recent poor control of diabetes, and he is he complies with treatment and is his taking insulin is right in appropriate way, and there is no complication developed with diabetes. But there was some notice we have noticed some episodes of maybe hypoglycemia during early mornings, because there was episodes of racing of hearts and sweatiness in the middle of the night, and there is changes in the poo habit, and there is uh, unable to tolerate the heat. So, and there were some issues at the school, but right now the about the bullying, but that problem has been solved right now. So my differential diagnosis may be um type 1 diabetes mellitus along with Dawn phenomena or Stomach phenomena. And my other diagnosis maybe celiac disease or any other autoimmune conditions like diabetes. Sorry, Edison or any hyperthyroidism.
Addison disease.
So should not say. I'm sorry. Maybe other autoimmune conditions. I
Hello.
unable to pick up. I actually unable to pick up what are
Yeah.
the flow.
Yes. That's why this scenario is repeatedly given. Because whenever we are trying to
Hello. Hello.
Dr. Abhishek, what was the last question that he asked?
Actually, he asked about the nothing. He asked about the diagnosis, differential diagnosis. What may be the cause of this poor DM control?
Okay. Okay. So what is the answer actually?
I don't know because maybe he is disconnected, na?
Oh,
Yes, he has disconnected maybe.
Sorry, guys, I got disconnected because of network issues. Okay,
Yes.
so the thing
Yes,
is,
actually, I want to ask you one thing. I take history haphazardly. I took what I did.
yes,
I asked for
yes,
the complications first, then went to I want. When someone said to me like this, for this scenario, you have to take the complications first. That's why I'm doing that thing and become messed up everything.
yes.
What will be the structure, appropriate structure of the history in this scenario?
Okay, so if there you started very well. So if there is symptoms of hyperglycemia, then we need to focus on hyper in the presenting complaint. Just like what are the symptoms of osmotic diuresis? Again, the urine is very important, and if his thrust is there or not, how many times you're going to this, I mean, for toilet at night, and you start with this, okay, with the frequency and urgency, and after that. In every scenario, I said previously also, so we need to rule out any dysmorphism because some dysmorphic child and syndromic child may be there. Okay, and you started very well, but the nutritional history, little bit of more after that. You check the compliance. Compliance is the key in this station in
Yes.
detail. So you need to ask about okay. So we basically the child is taking the insulin or someone is guiding because child is already 15, na? And then about the dose and the type of insulin, that is also important here. So you need to go over that part also. And after that,
Okay.
injection site you check, but the storage sometimes the storage
Yes, I
and
asked about.
date
I
of
asked about
expiry.
that. I asked about that. But
Storage.
yes, I asked about
Storage.
why to give. Yes, yes, I asked about where the insulin
Maybe
is
I
secured
then I'm
and
okay. Fine,
site of
fine then.
insulin, site change, leukoatrophy,
No
lipohypertrophy.
injection site. Okay, Baba, calm down.
Sorry.
Okay, fine. So okay. So I'm repeating then one more time. These are the important areas. That's why I'm telling you. Maybe I have forgot at that time. So the storage is very important. Okay. So how they are storing this insulin, and after that, specifically dose, because if they are following up with the endocrinologist and there may be some miss upon the detail about the prescription when that was last time they have changed their prescription, I mean dosage. And here you ask about the puberty, and puberty is one of the insulin resistance, so that's why puberty is very important. So nothing may be there in the history except this puberty changes. So that is the area we need to change the doses at the time. And after that, during your other system review, you got the information of some features of hyperthyroid, but I think, at that time not realize that that may be the one of the reason, right? And
I
down
said
and
about hyper.
sonography phenomenon, you
Okay. I said about hyperthyroidism in our DB, but I can't make it out what
no,
might be the.
that was in my mind. The diagnosis was puberty as well as hyperthyroid because the child is controlling well the dietary and everything. Okay,
Okay.
there was no school issue, nothing was there. But this is the condition where you can get autoimmune diseases along with
Yes.
diabetes. That is why this scenario is they're giving repeatedly. Uh, in maybe in every exam they are keeping this scenario, diabetes, either hypo or hyper, this type of scenario. Okay, so now we follow up, we need to probe very well. So last visit and the prescription, any changes in the insulin dose, is the child is insulin, just here that is basal bolus. Okay, so what are the other types of insulin? It is only short acting or as well long insulin? Not, usually they give it as long acting as well as short acting. So how frequently the child is taking? Okay, now any dose adjustment by self, because sometimes sometimes because this child is started when this child realized that there is some irregular, the blood sugar control is not good. The child realized, okay, at that time the child started to go to the gym as well. Okay, there is chance that she is thinking with gym and sometimes avoid, she or he can avoid the insulin doses as well. Okay, so last few months with exercise, even maintaining strictly the food and exercise and insulin, everything within 15 days is sometimes not possible to control the hemoglobin A1C. This is reflecting for the last 6 months. So that's why, last 3 months. Okay, so that's why this fluctuation may be there. Anyway, now systemic review, you change the heart rate. That is very important because the hyperthyroid scenario is given one of the time with this diabetes. So there was autoimmune hyperthyroidism feature. So if there is hyperthyroidism associated, how will you assess that? First question, there is heart rate. Not only heart rate, there will be sweating, weight loss, as well as hyperglycemia, as well as some eye changes, like
Exophthalmos.
oh, that will take time to develop basically. Yeah, possible, but we need to ask. Okay.
Okay.
This is chronic process, and that will take us time to develop. But we can even ask, okay, any changes in the eyes have you observed or not? Okay. So in this way, we need to go, and social history definitely important because I have selected the history. I have taken this scenario. The cause, the DD is mostly from my side, that was puberty as well as hyperthyroidism. But most of the cases in exam scenario, they are keeping the information in the social part, okay, because this diabetes type 1 especially, they are very emotional. If you see the guideline, they say that they're emotional as well as some psychological depression may be responsible for this poor control of diabetes. So this like social history is very important. But you talked about the school, that's fine. And any change of mood, you need to ask. But you thorough out, you take the history from the child, but sometimes you can also involve the mother also. So it is not possible that every time the child is giving the correct history. If there is mother and the child, we have few questions, especially the social part, we can ask, because most of the time the child will be refusing in the social environment what is going on in life. So mother can give the better history in that social, especially. So again, any skin spot, any muscle swelling you asked. In this way, no need to focus in every area, but important history is here, the social history as well as other system review that will give us the, and puberty definitely will give us the idea about the diagnosis, basically DDs. So you did well, but few modification because this is really sometimes difficult, this kind of scenario.
So what will be my exact structure in this case?
It's similar, but
How to
I
start?
really don't want to keep change. This is you need to start with the osmotic diet. I mean urinary part, because clinically, whenever you're sitting in apart from blood sugar level, that will be very difficult to take the history of diabetes. So urinary symptom
Yes.
is the first thing. Okay.
Yes.
After that, weight loss. So
Okay.
weight
And
loss, diet. Now you come to the part of compliance in detail.
Okay.
Compliance in detail,
Okay.
including site of injection, any hypertrophy and doses in a last prescription.
Okay.
And
What type of insulin? What type of insulin? Okay.
yes, what type of insulin? Definitely.
Okay.
Even in I have seen some of the scenario, the last recall, they have given that the child was recently changed into insulin pump, and after that got hypoglycemia.
Okay.
Okay. So that is different scenario, but the detail of that is compliance, including the details of insulin, what type of insulin the child is taking. Right? In this way, we need to solve this the thing. And if you already got an idea that yes, this is the reason for this hypoglycemia or hyperglycemia, after that you can throw over the social very cool and confident way, because the scenario is clear now. Right?
Okay.
And we need to we need to keep in mind obviously this down and Somogi phenomenon, because there is some idea, because nursing staff, I mean that is diabetic nurse, sometimes uh, gives some information about this phenomenon, sorry, about the control of blood sugar, how to keep the blood sugar in normal and the advised range basically. So they sometimes, what happens when this blood sugar chart basically they are checking, so nighttime there will be hyperglycemia, right?
No, night
Nighttime
time.
lasts, evening time, even
For
not
which
nighttime,
condition?
evening,
For dawn.
down phenomenon.
No, dawn phenomenon, no, tight control. The sugar will
Downs
be
are down.
normal.
Sugar
For
will
dawn
be
phenomena,
normal.
at night time,
Yes,
only
I
there
need
will
to.
be morning hyperglycemia. There will be.
Okay. Listen. So in the nighttime, if in the evening or nighttime there is hyperglycemia, then sometimes the child or maybe the parent will think, okay, nighttime insulin need to be increased, and they usually sometimes 1 unit or keep the blood sugar level a little down, so they can sometimes increase the blood insulin dose, and as a result there is morning and at the night near about 2 to 3 a.m. there will be hypoglycemia as a result of just hormonal effect. In the morning there will be hyperglycemia. So what is that, this kind of effect, what is that called?
Actually, what I know, in dawn phenomena, the sugar level at the night time will be okay, normal. The child is taking normal insulin. But what happened? You are right. There will be early morning hypoglycemia. For that, the counter regulatory hormones will be reacting, and it will be morning hyperglycemia there. So other than morning hyperglycemia, the other sugar levels will be normal for the dawn phenomena. Whereas for the Somogai phenomena, the sugar levels are not well controlled, and that time there will
Mm.
be hyperglycemia every time you can see.
Okay, so basically I mean to say these two phenomena we need to know very well. I am again repeatedly I am confusing with these two, but we need to just be confident in these two phenomena, because this phenomena can be asked in the exam. Okay, so this is the important area, and now they can move into the investigation and management part. So they will ask, okay, so what are the DDs of hyperglycemia in this child? So this is type 1 diabetes presented with
Dr. Pranab, can I just say something?
uncontrolled. Yeah. Yes. Yes.
No, I just
Please.
wanted to ask. Earlier, there was a case when we discussed about diabetes, right? So there was lipoatrophy and all. Did Dr. Abhishek ask about lipoatrophy lumps in the injection sites?
Yes. Yes. He asked.
He asked. Okay. And in the social history, I think Dr. Taman or someone, they said it could be better to ask not directly to them that if you are smoking or using partying drugs, rather we could say that we all as adolescents, we've been to parties. So maybe is
Indirect
there
way. Yes.
so maybe are you with friends? Are your friends using partying drugs? Yeah. And we know many teenagers who smoke in this age. If we give a leading statement, maybe they'll say, "No, doctor, I don't smoke." Maybe something like that, rather than asking directly. Yeah.
Directly. Right. So again, in social history, we
Uh,
need to be very, very sensitive way. We need to ask basically. So in different way, just like
mm.
Dr. Anisha said, in that way.
And Dr. Abhishek, I also wanted to give one feedback. We all have to train in that. Even I don't do it so well, but whenever we ask history, it is in the form of a questionnaire, right? Rather than that, if it is like a conversation, it would be better, because from what people have been presenting in the mocks, that is what I realized. Maybe in Tamana's class and all, it is more of a conversation than a questionnaire. Maybe we could try
Yes, you are
something like
right.
that.
Yes, yes, you are
Yeah.
right. You are right. Absolutely, you are absolutely right. Yes, I did
Maybe,
mess up. Yeah.
maybe that will come only with practice. Yeah, maybe. Yeah.
Yes,
Yeah.
yes, you are absolutely right. You are absolutely right.
Yeah. And even in clinical examination, I heard from some doctor, I think, I don't remember his name exactly. That doctor actually was telling that we have to talk continuously to the baby in clinical examination. While practice, we are you only used to asking questions, right? So maybe we should have somebody in the house and continuously talk to them and also check if we are doing everything because they will also divert us, right, with the conversation.
Yes.
So we have to see if we are doing everything in sequence, even when talking.
Okay. So in clinical
Yes.
session, what will happen? That will come automatically if we are confident enough in the examination process technique. Okay. So
Yeah,
if we are
yeah, yeah.
confident enough with
Yeah.
repeated practice, at that time will be just very much cool. Because we know that how to examine.
Yeah.
Okay, if the task is given MSK, okay, I will just do the MSK. At that time, our mind will be searching for the diagnosis. At the time, at the same time, we will talk to the child. Not even continuously, but sometimes it's always better to talk to the child because some children may have some low IQ level, and we need to talk for that reason. Not only for that reason, that is called engagement. That in their term, I mean SPCH leaflet,
Yeah, yeah,
you need
yeah.
to engage the child in a different form, like with talking or maybe in a form of play. Okay, so we need to examine in that
Yeah,
way.
yeah. Okay, okay.
Okay, okay. So, Dr. Abhishek, what are the details of hyperglycemia in this child?
So you have
What are the other
mentioned that, like,
possibilities?
so
No, no, no. I
you
have
have,
mentioned just only two options. There are
okay.
several other.
One is
We need to mention if
improper diet, taking junk foods or any sweets or snacks, less exercises. Next, improper dosing or inappropriate storage of insulin, inappropriate techniques, any infections like any UTI or any otitis media or like that. Any kind of
okay,
eating disorder, any kind of family disruption like divorce or separation or any stress in the school or in the home, or maybe inadequate family motivations, or like or any poor family support, or unable to understanding about the disease. That may be
okay,
the Dawn phenomena, or might be the Somogai phenomena, though that the tight sugar control is there for the Somogai. So you need to reduce the dose of the insulin at the night time. And there may be the, you said about the depressions and anxiety and puberty
yes,
and any kind of autoimmune diseases.
mm,
Uh,
like hyperthyroid, right?
and hypothyroidism. Okay, okay. And mm, this kind of, and eating disorders like any kind of eating disorder that might lead to overeating.
Okay, fine. So these are the causes. Fine.
Yes.
So now you have given the DD. So how you will? Okay. So yes, how you will manage this child, including the investigation?
Uh, in this child, okay. Uh, so uh, for the investigation, I need to do uh, complete blood, sorry, full blood count, along with the CRP for any infections or inflammations. I have to take the sugar alongside the HbA1c level, and uh, I need to check the electrolytes also, and do the urine routine and culture to rule out any urine infections. Do the thyroid test like thyroid function test, PSH and FT4, to rule out
So
any
if there is okay, wait. If there is any infection or any acute condition, don't do this because that will be erroneous. Okay. So it's better if the child is stable enough, apart from infection. Okay, you can do this. But as you said in the DT, you are thinking of infection as well. That's what actually you are doing this blood like CBC, CRP, all these things. So if you are suspecting some infection, then this is not immediate. You can put it, but later on.
Okay.
Okay.
And about the manage about the
So,
management.
that is the investigation basically depends on the severity of the disease. Okay.
Yes.
So if the
Yes.
child is having some respiratory distress as well as fever and we was thinking that diabetic ketoacidosis is the chance of developing. So at that time we will do the blood gas as well as other electrolyte and blood ketone as well. Because in our setup we are not doing regularly the blood ketone, but in UK they are giving more importance to it. They have some special kit that is called dips, like dipstick actually. So ketone sticks there. No? So at
Yes, yes.
home they are also monitoring this ketone. This is the only and the most specific of diabetic ketosis. So that's why we need to mention the ketone level in the blood. That is more specific rather than urine ketone. And urine RE also you need to mention. Okay.
Actually, what I know, they do
Okay.
the
Now.
urine ketone in at home, but when if there's any problem, that's blood ketone in them. That too in the hospital, I think.
I don't think because blood ketone can be done with the stick at home also.
Okay. Okay. Thank you.
What I know basically, but okay, we can find it out. No problem.
Yes. Okay.
Because if you go through the sick day rule, diabetic sick day rule.
Yes. They figure they have the written the blood ketone every 4 hourly.
Yeah. That's
Yeah,
why I just
Dr.
said.
Pranab. Hello.
Yeah.
Yeah, so they can check their blood ketone at home as well. As you mentioned, there is sick day rule.
Mhm.
So as long as
Yes.
child is eating at home, they can manage at home.
Yes.
And yeah, and if the blood ketone is like, I think it's more than 3, then they and child is not eating or look dehydrated, then they immediately come to
Ambulance.
hospital. So they correct the ketone according to blood ketone and the blood glucose.
You are in the UK. Is there any stick and you have to take how to do the blood ketones like
Yeah. There is a stick. So they it's like strip, like urine dip. They have
Keto stick.
ketone strips as well. So in when for every newly diagnosed child, they provide the kit. So in that there are strips to measure ketones, strips to measure blood glucose. Everything is there. It's all provided in the diabetic clinic as well. The diabetic nurse provides them.
Okay.
Thank you.
Okay.
Now, okay. So, if this is the first time presentation of diabetes, with type 1 diabetes, then what are the tests you will do? Newly diagnosed
actually,
case.
no, it is not the newly diagnosed case.
It is not that newly diagnosed, but examiner is sometimes interested, because there is some association with other diseases. That's why.
Hello.
Yes. Can you hear me?
If yes. Hello. I am able to hear you. Hello. Yes. If this is a new case of diabetes, if it's a new case of diabetes, then I have to do as well as I have to do the fasting blood sugar along with the PP blood sugar, to PP to our blood sugar, then HbA1c level, then I have to check the C-peptide level, and then the insulin levels. Alongside, I have to rule out other autoimmune conditions. So I have to do anti-GAD antibodies, anti-islet cell antibodies, and GAD, islet cell GAD, and I have to do for other autoimmune conditions like ANA, hypothyroidism, celiac disease. I have to screen for that.
Yes. So specially, we need to remember two special things. That is, this is very common association with type 1 diabetes. That is thyroid as well as celiac. So this is the thing. And after that, for the diagnostic purpose, we can do islet cell antibodies. Yeah, islet cell antibody and GAD antibodies. Okay.
Yes.
And thyroid function test and IgA level, because if you are suspecting celiac, then IgA level is important, right?
IG and total IgA total.
Yes, yes, yes. So how you will manage this child? Is the child is stable enough, no need of admission, and there is hyperglycemia, and no urinary ketone, or maybe one or two ketone is there. That is not significant in the urine. So the child is not in diabetic ketoacidosis. Only hyperglycemia is there, uncontrolled diabetes. How you will manage this child?
Actually, I will involve my consultant along with the multidisciplinary team involving our pediatrician, endocrinologist, dietitian, social worker, ophthalmologist, eye doctor, and nephrologist. Actually, I will involve the dietitian for proper diet and avoid less of any snacks or any lot of sweets. I will involve the child for the more exercises and do the regular exercises, and I will telling about the compliance of the treatment and involve the diabetic nurse for that, so that again they will teach the appropriate technique of giving insulin, changing the sites along with the proper storage of the insulin, and then I'll involve the endocrinologist to involve. So, is there any dose adjustment needed or any other kind of insulin needed, or uh, that I have to ensure, and I have to also involve the family for the family motivation, support, and disease understanding. That is very important, and I will talk to them about the sick day rules and importance of the taking the diabetic diary to check the blood ketones and the blood glucose level monitoring, and about the hypoglycemia awareness also, and and involve the school support for the school nurse and psychologist.
Exactly. And anything more?
Actually, I don't remember.
Sometimes you need to mention the bracelet. Bracelet
Yes,
also.
this.
So don't forget bracelet. Don't forget bracelet.
Yes,
If any hypo is there, the child is unconscious. That time this bracelet will help, because in this whenever the child is returning from school or maybe at
Yeah, and
yes,
always give the red flag to the sign to the child and family to watch out for the DK red flags. So if the child is vomiting, not taking medicine orally, or if there is any respiratory problem, difficulty in breathing, deep respiration, or any abdominal pain, to come back to the ED or
yes.
call.
yes, yes.
Okay. So what are the complications may happen in this child?
That can be acute complications is two. One is diabetic ketoacidosis, and because of the maybe high insulin, giving high insulin, there may be hypoglycemia, and there may be some long-term complications like macrovascular, like hypertension, like coronary heart disease or cerebrovascular disease. And for the microvascular, it is the retinopathy, nephropathy, and neuroperipheral neuropathy, leg ulcers, chronic infection in terms of infections.
Okay, how you will understand this nephropathy is developing?
Uh, I have to do the. I have to check the blood. I have to repeatedly monitoring the blood pressure along with the. We have to do the urine albumin creatine ratio, the MACR.
Yes. And if the child is developing hypertension or diabetic nephropathy, do you have any suggestion, any kind of medicine which group of
Yes.
and uh,
Yes. Actually, I have to tell about that. For the controlling, you have to strict control of the blood sugar, blood pressure, lifestyle modifications, and lipid levels. And if it is developed, then we can give ACE inhibitors or the angiotensin receptor blockers, ARB. So For that, they might prevent this, you know, diabetic nephropathy or the peripheral arterial diseases.
Right. Right. So if the child is developing diabetic ketoacidosis and developing, I mean, the presence with coma, okay. So how
Yes.
will you manage this?
First of all, I have to, if the child is present with diabetic coma, I have to maintain the airway, breathing, circulation first. And then I have to do some tests. I have do the IV cannula and do some tests like the complete blood count along with the inflammatory markers, along with the electrolyte level, particularly the potassium level, and do the blood ketones along with the urine. I have to send the urine samples for the urine ketone and urinary.
Okay,
Then I
all this
have to give.
investigation you have already sent. How will you manage this child?
Yes, then I give the
The child
if the
in
child presents
coma.
with shock. If the child presents with the shock, then I have to give the NS bolus.
How
And
will
if
you
the
assess that the
I
child is in shock or no?
I have to do the actually I have to check the ABG. I have to do the ABG. If the pH is less than 7.1, that is such a 10% dehydration. So I have to correct like that. If it is 7.1 to 7.2, then it is 7% dehydration, and the 7.2 to 7.3, that is 5% dehydration. Along with, I have to check the blood. I have to check field for the pulses. If the patient is in shock, there will be some tachycardia along with the narrow pulse pressure and the BP will be low. So at that time, I have to need to give the bolus.
Okay.
And first hour we will
How
not
you
give
will
no
give that
insulin.
bolus? How many
Okay,
boluses per kg?
20 ml per kg.
Okay. First of all, give 10. After that, yeah, that will be decided. I think if we give maximum bolus, because what happens most of the time before, usually in different settings, when the child reaches to the tertiary center, so already most of the child already received maybe more than even 20, and this child is already, I said, in coma. There is chance that already there is cerebral edema. So we never know. Okay, so the bolus is we need to be very careful about the boluses. So in the guideline, I think that is mentioned about 20. I think. No?
I have to check the guideline.
No, you are talking about decay.
20. Yes.
It is 10 initially. If it is shocked, then only 20.
Yeah, there is there,
should
initially it's
we never
10.
start
After
with
that,
20.
10.
Never start with
Yes.
20 decay. It is 10. Only child is in shock, then only 20.
Yeah.
And
Yes.
that 10 also you have to deduct from the total maintenance and the correction.
Maintenance.
Okay, and
Right.
48
No,
hours.
if it is not in shock, then I have to deduct. If he is in shock, I don't have to deduct.
Yeah.
Yes.
Obviously,
That is
right.
absolutely.
Okay.
And
Okay. So continue.
you
So,
said child had he is developing signs of coma, na, raised ICP. So we have to at that time we have to give the mannitol or 3% saline, na?
3% saline.
he's coming actually. I was about to ask this question. Anyway, yes.
Yes, if the
So
patient is
how?
cerebral edema, then I have to give that.
So that
Mannitol
would
or
be the first answer.
no, if the patient develops cerebral edema, then why?
No, Dr. Pranav asked about that he is in coma, na? He is going in coma.
Yeah, at presentation there was just
Actually,
the child was going in coma. I said that, but definitely there were, if there is circulatory collapse, I mean shock, definitely one dose of 18% you can give. After that, mannitol either, and most of the sedatives nowadays using 3%. Mannitol is absolutely nowadays, so 3% is more appropriate even in the guideline. So we can use 3% nowadays. Okay.
Yeah. And if the child is developing coma, everything changes rapidly. Like you have to involve the anesthetist to secure the airway as well. and you have to you need extra pair of hands to help. You need to secure 2 IV lines. Somebody needs to call the transport team, as you need to discuss the tertiary center as well, as you will be transferring the child soon. So you will need the discussion and their advice what to do in that case. Or you involve the endocrine consultant as well at this stage.
Definitely.
Yes, definitely.
And we need to admit the child in PICU, not in
Yes, yeah,
ward or high dependent. Definitely PICU
yeah.
consultant will be there, and we take
And
shift
you
the child.
have the
Okay.
maintenance fluids at that time.
Yes.
Yes,
Okay,
definitely.
so these are the areas of discussion in the exam. Okay, so anywhere they can go from diabetic, especially this DK is very important, and some of the video is there, the Kushmal breathing or acidotic breathing. I will show the video, but that is also important for video session. So straight away they will just discuss the DK. DK is very important. So in this way we can discuss diabetes.
Dr. Pranab, I will forward the guidelines to you guys that we usually use in UK. So that's for
There is a BISPEC guideline. There is BISPEC right now following.
no, that's a CATS guideline. So that's Children's Acute Transport Service. So this is like the people who transport the children to tertiary center, and they deal with this very severe sick kids who eventually needs intubation. So when child
Is it same with the pediatric guideline or something different?
it is pediatric CATS guideline. So it's a practically routinely used for a very sick child who needs PQ admission to transfer out. So
No,
there are
I'm talking about the guideline which is already given in the pediatric guideline. That is same thing or something different?
I
Have
think
you gone through the guideline?
no, I
So
haven't
Dr.
gone to pediatric guideline, but
Nisha, will
this
they be
is like
asking us all these things that, okay,
yeah,
will they
this
be
is like
asking us that, okay, you are
nobody
in
will
a
deny. No,
secondary care center, you want to refer to tertiary care?
Scenario. Can you
Yeah,
repeat?
sure. So this is 13 years old Christy, who has presented with several episodes of hypoglycemia for the past 3 months. She was diagnosed at 5 years of age with type 1 diabetes, and she recently visited the GP, who did further evaluation and did some basic blood tests. They were all normal. The RBS was also normal. Mother's name is Jacqueline. I have to take relevant history.
Okay, fine.
Yeah.
Take your time. After that, we'll just start. Okay.
Hi, am I talking
Welcome.
to 13-year-old Christy?
Yes,
Okay.
doctor.
And
Christy.
is Christy's, are you Christy's?
Mother,
Hi,
Jacqueline.
Christy. Nice to see you today.
Yeah.
And are you with your mom, Jacqueline?
Yes, Jacqueline.
Oh, hi. How may I address you?
Yeah, I said
Okay.
Jacqueline.
I'm Dr. Anusha. I am here to inquire. I'm here to inquire a few things about Christy's condition. So I have received this letter from GP, and I would like to know more about her symptoms. Would it be an appropriate time, Jacqueline?
Yes, we are here for this only.
Okay. Time will know, Christy. I will also be asking you a few questions. Okay. Okay. So, okay. So I've been told that you've been having several episodes of low sugars over the past 3 months. Can you tell me about it?
Yes, doctor. I really don't know why she sometimes has some fainting attack at the school for this low blood sugar, and they gave some glucogel, which is there in the bag, school bag, and yes, that not only the one time, but at home also there was so much of low blood glucose in the morning, and we had to again do this uh, sugary drink. So after that, blood sugar got controlled, but we really don't know why this is happening, doctor.
Okay, okay. So Mrs. Jacqueline, can you tell me what made you think that she has, like low sugars, and what made you check her blood glucose levels?
Basically, this fainting attack was there at the time of school, and after that we were so much of worried. That's why we are checking our blood sugar on regular basis, maybe 2 or 3 times in a day. And we found that the sugar level is always a little bit of lower side, after taking, giving some adequate dietary management as well.
Okay, okay. Mrs. Japin, I see you're really handling the situation well. Can you actually tell me at what time of the day this sugar levels are going down?
There's no particular time, doctor. Basically, we are checking this thrice a day, 3 times a day. So every time the blood sugar is low or down.
Okay, so you check the sugar levels before the meals, is it?
Yes, mostly before the meals.
Okay. Apart from fainting, has she had any other episodes? May I ask you, Christy, like, have you been aware of these episodes and like, how did you feel about it?
How can I feel about it? It's a very stressful condition, doctor.
No, I mean, what are the things that you feel during the time? Do you feel that your chest is pounding and there's excessive sweating and you feel giddiness or blurring of vision, anything like that?
Yes, with this hypoglycemic attack, there is, we know that there will be some sweating, some palpitation, and raising of heart rate, and all these things was
Okay.
there during the attack. And what
I really
sometimes she
appreciated, Christy, that yeah, that
never
you are
stop,
aware of the symptoms of hypoglycemia. Hmm.
never stop the role there. You will miss some vital piece of
Yeah,
information.
yeah, yeah,
Basically,
yeah,
this,
yeah, yeah. No,
whenever
there
I
is
am
some
trying to speak, you are just
network
stopping.
problem, Dr. Yeah.
Okay, so at the same time, what happens for last 4 to 5 times, I have noticed she is complaining of tummy pain, doctor, and sometimes vomiting as well for last few days.
Okay, okay. So these symptoms have been present only for the past 2 days, is it?
No, for last 15 days, she is having this tummy pain on and off and vomiting
Okay.
maybe 3 or 4 times for last 2 weeks.
Oh, that must be really difficult. So are you vomiting after every meal, Christy?
There is no association with feed, doctor.
Okay, okay. So do you feel that you're just the throwing up without any, any nausea? You just throwing up, and is it going far? Association with any headache?
No, no headache is there, and throwing up not forcefully. It's just vomiting.
Okay. Uh, where is the tummy pain exactly, Christy? Can you tell me? Can you localize in your tummy actually which place aches?
It's a not non-specific, doctor, all over the time. There is no specific area.
Okay, okay. And is there any diarrhea? Any loose stools?
No, doctor, no such use to it, nothing.
Okay. Can you tell me more about your, hypoglycemic episodes? Since you realize when you are actually having these episodes, were there any precipitants for this? Something like, like exercise or games time in your school, or that you've been skipping meals, anything like that?
Yeah, in the school, what happens last time? There was fainting attack along with after giving this glucogel medicine. Child was absolutely fine, but
Sorry?
when this fainting attack was there at the school, at that time, the school nurse given some glucogel. Okay, and after that they
Okay.
measured the blood pressure and they said blood pressure was very low, and they gave some water to drink at that time. And after that we are visited we have already visited the GP for that, just after this attack, and GP also said the blood pressure is really little bit of lower side. And all of the time in the day and night, she is complaining of lethargy. I don't know why, doctor. Because of maybe this hypoglycemia attack, the child is not
Yeah.
feeling any kind of energetic nowadays for last 3 months maybe.
Yeah, could be Mrs. Jacqueline. Yeah, I can understand your concern. Maybe we will have to know more about these episodes, to come to a conclusion. So, has there recently been any increase in the exercise that she's been doing, or has she been skipping meals? Has she been busy at school that she couldn't take her meals at appropriate times?
No, 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 doctor.
Even
She
Christy
is
can tell me
taking.
about it.
Yeah, Christy is there with me, but she never complained of nothing such event was there. She is taking the meals in a regular basis, and there is no chance that for this food habit there is any irregularity or for this hyper.
Okay. Basically, what I mean to ask is, has her physical activity increased over the past 3 months compared to earlier in any form? Maybe she's
No, rather
joined
than
some ballet classes or something like that.
I okay. So I said there is no increased activity, doctor. Rather than I'm saying that my child is having low energy in everywhere. She refuses to play with the friends as well at the school. Okay.
Okay, Jana. Okay. Sorry, I got that wrong. Okay. Can you tell me about her urine? Like, how many times she's passing urine in a day?
Okay. I don't think there is increased frequency, doctor. So that is normal, I think. And then
It's
about
normal.
8 to 10 times mostly.
Okay. And is she waking up in the night to pass urine?
Uh, Sometimes, but I will never say that is increased. Never say. Most of the
Okay.
time, she sleeps well, very well.
Okay. What about her eating habits? Like, has the quantity she's eating changed less or more? Has it become less or more?
This is a repeat question, doctor. I say everything is fine with the dietary, and we are strictly following the dietary advice. So there is no association with the feeding, doctor.
Okay.
9 minutes after
Okay. And
9 minutes after.
the weight gain or any weight loss? Uh, Weight gain or weight loss?
Not so much of significant. She is lean and thin. That's all.
Okay. Like always she's been, or any changes in the past 3 months?
No changes in the last 3 months, doctor. No changes. She is remaining like same.
Okay. Okay. Any intermittent illnesses that she's been suffering from in the past 3 months? Any fever, any sort of an infection that needed attention?
No. Nothing.
Okay. Okay. And about her insulin, can you tell me what is the type of insulin she's taking, the names, the doses?
She is on injection, that is one long acting and short acting before the meal 3 times daily.
Okay. So who gives her the insulin?
Actually, at home we are supposed to give this, but we have already trained her along with this diabetic nurse, and she is able to take this very well. There is no problem with the insulin.
Okay, that's good. Uh, so how are things at school? Like, is she able to administer herself? Christy, can you tell me about that? Are you able to give yourself the insulin shots in school? Is there any issue?
No, there is no issue, doctor. I am taking this medicine regularly at school, and
That's very nice.
sometimes
Yeah,
with
yeah,
the involvement of school nurses. Okay.
that's nice. That's nice, Christy. Okay. Now, actually, can you tell me more about your diagnosis, when you were diagnosed, and what are the teams you are following up, the dietitian and all that?
Yes, dietitian and pediatric consultant, as well as some gland doctor and the social worker, psychologist. We are following multidisciplinary team in a regular basis. Okay, and this has been diagnosed when Christy
That's
was
very
five
good. That's very good.
when Christy was 5 years, this has been diagnosed. At that time, she needed admission. Okay.
Okay, okay, good. Okay, and has your gland doctor tested you with any tests recently?
Yeah, that is last time, last year we have done several tests, including the thyroid and some uh, that is called some different, I forgot that, but IgA and celiac. All these tests was normal. There's no issue with it.
So that's good to know actually. Can you tell me about her menses? Has she started her periods?
Yes, and that's regular. No issue with that.
Very good. I see she's growing up. And has she had all her jabs till now?
Yes.
Okay. Apart from this, Mrs. Jacqueline, have you noticed any difference in her activities? You told me she's lethargic. Apart from this, have you seen her that she's disturbed, mentally disturbed with any other issue, probably from school or amongst friends, and anything like that?
No, doctor. I don't think she is a very happy child, and there's no issue. And psychological counseling has been done, and he loves to play with the friends, and everything is fine. There's no psychological issues.
Okay, Mrs. Jacqueline, can you tell me more about your family? Who lives in the family, in the house?
It's me only, doctor, because my husband died because of diabetes in just a few years back. So I'm taking care of uh, my child, only child.
Oh, I'm sorry about that, Mrs. Jacqueline. It must be really hard to be a single parent. But I see you're really doing
Yeah.
well. Can you tell me any? Okay. And, are there any other diseases in the family? So probably something associated with any thyroid issues or any other abdomen issues in the family.
No, just uh, my husband had diabetes and he died of nephropathy, diabetic nephropathy. That's all.
Okay. So I'm sorry to ask you. It must be really difficult for you, Mrs. Jacqueline. But can you know about your financial income and how we are handling the family?
Yeah, that is really difficult. But the social worker are helping a lot. We are getting all the financial support from the social worker, and I am also struggling or maybe working and managing our family. Yes. Time up.
Okay. Cl- okay. Just can you give me 1 more minute? It was all network issues. It's very lag actually. There's a lot of
Oh,
lag.
30 seconds.
So Christy, quickly, may I just ask you a few things? So how is life as a teenager before these 3 months? Like, are you enjoying partying and all that? How is all that?
No, doctor, I'm a very, just, I'm not involved in any kind of party, but just please, I love to play with the friends only in the school and I'm busy with my studies. So it's rare that I have attended a few of the parties, like birthday parties, very rarely.
Maybe you should start going to more of them. You can make a lot of friends, Christy. So yes, we've all been there and we've all enjoyed that time. And many teenagers at this time they usually smoke as well, also alcoholize. So do your friends do anything of this?
No, doctor, I don't like beer.
Okay, it must be difficult to discuss such things in front of your mother as well. Sorry for that, Christy. Um, okay, may I just ask about your periods for one last time? When did you start having your periods?
So I have started near about 11, 12, 11 years or maybe 12 years, I can't remember. But it's now regular, with no issue with that.
11 years. Okay. Okay.
Anything more?
And how do you store the insulin? Yeah, how do you store the insulin at school?
Okay, so there is a refrigerator. So we just store over there, and the school nurse is taking care of
Okay. Okay. Also, have you been given directions about your sick day rules, like how to overcome all these episodes?
Yeah, the nursing, I mean, the diabetic nurse teaches everything, every single thing about sick day. So we are very aware of that rules.
Okay. That's very nice, Christy. That's very nice. You seem to be a very disciplined and informed child. Thanks for your time, Mrs. Jacqueline, as well.
Summarize.
Christy, wish you a speedy recovery. Thank you.
Summarize.
Dr. Pranab, I don't know, there's a lot of network issues today. It's almost like 10 to 20 seconds lag between what I'm talking and what I hear from you.
Okay, no problem, no problem.
Okay.
Summarize.
Okay. Okay.
Summarize.
So today I got the opportunity to talk to a 13-year-old Christy who has come with complaints of several episodes of hypoglycemia for the past 3 months. She has gone to the GP with basic bloods being normal, and she was accompanied by her mother. So from what I inquired, she seems to be a happy child and attending her school, and a well-informed child taking her insulin regularly, and she has. Mm, and she's being followed up also regularly. No changes in her physical activity as well as the eating habits. And I cannot also find any new stressors that could have led to these episodes. Her father died of diabetic nephropathy. Yeah, I would like to examine the child and do a few more investigations.
Okay, okay. So what exactly your diagnosis? Why you are thinking this child may have hypoglycemic attacks?
I'm just thinking, Dr. Pranab, 1 minute. I don't know. I'm just looking at my history. I'm looking at my history, whatever I've collected. I didn't ask about lipoatrophy. I don't know about that. Was that lipoatrophy?
That is also negative. I'm telling you.
Everything is negative, Dr. Pranav. I
So
don't want
what?
you to be my
Okay.
examiner.
Not like that. Today we have 9 people here.
Just kidding,
Okay.
Dr. Pranav. Just
So
kidding. Yeah.
okay, today we
Okay.
have 9 people here. All of us should remember this scenario because this is little tricky. So if you getting hypoglycemia, so that's why they are giving this diabetes repeatedly, either hypo or hyper. So if there is hypo, then we need to rule out a few special area.
What is the age of the child, brother?
It's 13 years.
Okay.
One positive history of tummy pain and vomiting for the past 15 days, Dr. Pranav. But that was only for the past 15 days, not before that.
Yeah, Dr. Preeti messaged that someone please repeat the scenario. Okay, there was, yeah, share the screen. I have not given this just this scenario in a written format. So I'm describing the scenario one more time. 13 days, Christy presented with her mother having history of recurrent hypoglycemic attack for last 6 months. Last 3 months. Okay, and there was some history, positive history, but Dr. Anusha not mentioned that particular. She's taking just like what you have included the history in that is not significant, no clinical correlation with this history basically. So what are the positive history you have got from this child, Dr. Anusha? Then after that I will come to the conclusion. So this is very important history, and we must remember, with 9 people here, we must remember this history because this scenario has been given more than 3 times. Okay, and this is tricky, really. Someone may got confused with the scenario. So that's why it's little tricky. We'll discuss and this.
So you said that she gets tired very easily and she's not in energy. was
Let her
history
say,
regarding
let her say.
okay, okay, okay.
Yeah, I was about to say the same thing, Dr. Pranab, that she's getting very lethargic. I don't know if it is pernicious anemia, maybe that is associated. I didn't ask for any breathlessness during walking and any hyperpigmentation in her hands from, like tummy pain and vomiting is also there. Maybe I don't know if it is from the pernicious anemia or from any new onset Addison's. I didn't ask for hyperpigmentation.
Well, then you lost the case, lost the game, lost the station. So that is the area. So this is basically this hypoglycemic attack because of addition. So addition, this scenario has been given with type 1 diabetes, but sometimes type 1 diabetes may not be there in a clue. So you will unable to find out any clue during the history taking. So we need to find out why the child is having this symptom. Just like in the school there was low BP, there was vomiting and pain abdomen, and the child is feeling lethargic. At the same time, we need to ask for any skin pigmentation is there or not. Any gum pigmentation, oral cavity, is there any pigmentation? Lips, is there any pigmentation is there or not? Okay. So that will
Dr.
give
Pranab,
us
but this
some of
tummy
the
pain and vomiting, you said it was present only for 15 days, but hypoglycemia has been present for 3 days, right? 3 months, right?
yes,
Yes.
yes.
Okay.
So
Okay.
this can be from on and off from several days. So I have given just like an idea.
Okay. Yeah.
But
Understandable. Yeah. Could be. Yeah.
Hypoglycemia, type 1 diabetes, definitely we need to probe over this area for rule out this additions, because additions has been given several times, more than 3. That is the thing I want to say. Okay. So repeatedly I'm saying, when you are starting the history taking, you need to ask for dysmorphic features, please. We never know the child is dysmorphic or not. Okay. And rest of the thing you started very well and completed very well. According to last time, you just taken the social history very well. No issue with that. But again, you need to probe over that particular area. Okay. So if there is secondary adrenal insufficiency, then adrenal crisis will be there. No? So that is emergency.
Yeah. Yeah.
At that time,
Dr. Pranab, is there anything else I
may-
can ask about the adrenal, the disease, Addison's? You told about hyperpigmentation, skin and the lips. Is there anything else I could ask?
there is no, okay. If sometimes there is possible, they will give some information about the blood result of low sodium and hypoglycemia. That is the only clue sometimes they can give, and sometimes they are not giving
Okay.
this clue.
Great.
Otherwise, the clue in history, there will be low
Okay.
BP, and the child will be lethargic, and this pigmentation will be there, hypoglycemia will be there, pain abdomen sometimes will be there. These are the only clue. And family history, as you say, autoimmune diseases, we need to prove for autoimmune disease. The father died of the similar kind of diabetic nephropathy, so that diabetes was there. Right. So if there is
Okay.
hyperpigmentation, autoimmune disease, then what are the DDs possible here?
Sorry, if there is?
If there is hyperpigmentation as well as this diabetes, and you are thinking of
Yeah.
Addison
It could
disease,
be first thing I'm thinking of is Addison's disease, probably because it is an autoimmune disorder. Another thing I would think of is pernicious anemia with vitamin B12 deficiency.
vitamin D, B12 deficiency, that will cause hypo.
Hyperpigmentation, na? Yours hyperpigmentation, right?
Hypoglycemia.
Basically, I think she's thinking of celiac. That is why malabsorption. That's why, right?
Yes, celiac is also
Sometimes
possible.
malabsorption, celiac,
Yeah, maybe
secondary to
celiac is
which
also possible.
that is also will cause hypoglycemia, no? Because of malabsorption. That's what you're thinking, right? No.
No, he asked me
So,
hypoglycemia with hyperpigmentation, isn't it?
So celiac will cause
hypoglycemia,
malabsorption of
hypoglycemia.
nutrients, B12, and everything.
Yeah, maybe that could be.
But that is too long a
That
shot.
could be. Okay, okay. So what are the causes? What are the causes? Maybe the causes of this Addison disease of the etiology. If you are suspecting Addison disease, then what may be the causes? Number one, autoimmune, and
Yeah, well, number one is autoimmune, and from the infections it can occur. Something like TB can cause it, and
yeah.
also infections can cause it. And if there is any other extra suprarenal gland mass that is compressing over the adrenal gland, it could cause Addison's disease. Because Addison's is primary adrenal insufficiency, right?
What are the investigations you want to do for this child?
I would since I'm suspecting of first, I would like to check the FBS, PPBS as well as the HbA1c for the child. Next, I would like to do the urine sugars, and next I would like to do the no, not serum cortisol, urinary cortisol. And then I would like to do a synaptin test, ACTH suppression test. I would like to do.
Okay, so these are the diagnostic
Yeah,
tests.
which
Before
at
that,
0 minutes, 30 minutes, and 60 minutes. Okay.
wait. So if you are doing the blood test, first go for just like full blood count. I repeatedly say just say full blood count. I will just look for any anemia is there or not. I will do just urea and electrolyte to see any electrolyte imbalance is there or not. Just like expected result will
Yeah,
be
yeah, yeah.
low. Expected result
Yeah.
will expected result will be sodium low sodium and
High
high
potassium.
potassium.
Yeah.
Okay, blood sugar you mentioned. Then the next test that is towards the diagnosis, that is 24-hour urinary cortisol, right? Or early morning cortisol,
Yeah.
that 8
Yeah.
we need to take. And the ACTH level. ACTH level will be elevated, and that is mostly responsible for this hyperpigmentation, right? And
Yeah.
what other test you do? What?
You want to tell me about? You want me to tell about the ACTH test? I will
No,
do. Yeah, synaptin suppression test. I
that.
will do.
Yeah,
Yeah.
that is diagnostic test. But before that, you can also tell the plasma renin activity. The renin will be high, aldosterone will be low,
Yeah.
right?
Yeah.
And then the short synaptic test you can say
Okay.
that will be given at
Okay.
30 minutes. After that, 60 minutes, right?
Yeah. So I will be checking both
Short-synaptic and
CBG and
long-synaptic.
serum cortisol at 0, 30, and 60 minutes.
What other investigation you want to do apart from blood test?
I would also like to do a CT abdomen to see the child's abdomen and the adrenal, basically.
Okay.
Also, as part of the screening, I would like to do a thyroid function test because even hypothyroidism can lead to such episodes, hypoglycemic episodes.
So there will be features of hypoglycemia, hyperthyroidism in the history. So no such history is there, na?
Yeah.
Hyperthyroidism will cause hyperglycemia,
Yeah.
not hypoglycemia, right?
No, I said hypothyroidism. Hypothyroidism.
Okay.
Yeah.
Hypothyroidism, there will be weight gain, constipation.
Yeah, those things are not there.
Yeah. So you can do definitely in a diabetic patient, but for this test, if you are suspecting Addison disease, you have mentioned that CT scan of abdomen to look for the look at the adrenal, and after that, any other test, MRI brain can be done. See,
Yeah, MRI brain can be done. MRI brain can be done to see if it is to see the pituitary and the hypothalamus,
Yeah.
to see if it is secondary or tertiary adrenal insufficiency.
Yes, and if there is severe hyperkalemia, then we can do some ECG as well. Some changes will be there, na?
Yeah. Yeah. Done. Yeah.
Okay, so how you will manage this child?
I would like to first examine the child completely on all the systems, and I would like to plot the child's growth on an age-appropriate chart. And I would like to check the vitals of the child, including the blood pressure, and then do an abdomen examination. Following this, I would like to inform my consultant and also the endocrinologist for further evaluation. And I would like to first identify the reason for this hypoglycemic episodes, right? So I will identify the cause for this by doing these tests.
Okay, then any advice?
Then I would like, if it is confirmed as Addison's disease, yeah, if it is confirmed as Addison's disease, then I would like to supplement the child with hydrocortisone as well as fludrocortisone, and I would like to advise the child to drink adequate water, and to advise the child on sick day steroids. Yeah, sick day rules I will explain to the child.
Okay, what are the advice you will give to the parent?
The child can undergo routine immunization because this is only physiological level of steroids and not stress dose. And yeah, I will explain about the sick day rules to the mother and how to identify the acute episodes where the child might actually have fainting and yeah, low BP, tachypnea.
Okay.
Yeah.
Any bracelet?
With abdomen pain and vomiting. With abdomen pain and vomiting. Yeah, and also to wear a bracelet. Yeah, and also to carry the patient pediatric steroid treatment card with them that will explain to them about the sick day rules as well as for emergency management.
Yes, so these are the so patient education basically. Okay, after that steroid card, bracelet, and this hydrocortisone injection. Okay.
Yeah.
And we'll just advise to come to the follow-up regularly. Right? So this is a very, very important scenario we need to do. Repeatedly, we need to read this the information from different sources about the detail of Addison disease and with diabetes. Okay. This is very important. And okay. So any other feedback, guys? Otherwise, we'll move for the next. Any other feedback? So we are 9 people here.
We can go to the next one.
No, I think they can just ask how do you manage the hypoglycemia in this scenario, no? The emergency management of hypoglycemia.
Yes, that
Yeah,
could be asked.
basically it is because of steroid deficiency. So as we start supplementing the steroid, these episodes should actually ideally decrease, right? And if the child actually goes for
Mostly,
hypoglycemia, yeah, if it is actually identified as adrenal insufficiency, then the first thing they have to do is give her a dose of IV hydrocort, IV or IM hydrocort, right?
Yeah.
Rather than giving glucagon.
Yeah.
Yeah, there's actually age group where 1 to 5 years, like less than 1 year, they give 25 mg stat, and 1 to 5 years, they give 50 mg stat, and beyond 5 years, they give 100 mg stat. Following this, they will give the rest of the dose. But if the child is stable and having only a few symptoms, then maybe they can give oral doses only. and check if child is
Can you
getting
go
better.
slowly? You're speaking so fast. Sometimes it's difficult to
I'm
recognize.
so sorry. I'm so sorry, Dr. Kumar. Maybe I'll just share the the leaflet. Maybe that will be more useful.
Yeah,
That is actually
yes,
there's
yes.
guidelines. Yeah, BSPED guidelines is there. Yeah, sorry.
It's okay. So we are 9 people here. Remember, just I'm telling repeatedly, one of us definitely will get a scenario from diabetes. Definitely, 100%. Okay. So we need to read this diabetes, endocrine, especially this diabetes, very detailed in detail. Hypo as well as hyper. Okay. Any other feedback, guys? Otherwise, we can do another scenario quickly.
Actually, in this, they have given that the mother itself should be given the hydrocot injection, a vial with a needle actually, and they should be taught it.
Yes, you share the leaflet. That will be easier.
Yeah,
Okay.
yeah.
And
Yeah.
this part, basically this part, how you will teach the mother, that may come in the communication as well. How to use the sick day rules, basically. Okay, any other feedback, guys? Otherwise, we'll move for the next.
No, no.
No? Okay, fine. So next scenario is, I'm giving a scenario, okay? So next scenario is 15 years of age, Rose is a known patient of juvenile idiopathic arthritis for last 5 years, and nowadays she is becoming more obese. Okay, obesity is there, and you need to talk to the mother having some difficulty in respiration because of this obesity. Okay, and there is some increased frequency of urination as well. So you need to talk to the mother and the child. Her mother is Rebecca. Okay, so you need to talk to the mother as well as the child about the disease and the condition, and after that we can discuss the management plan.
I can try that, Dr. Pranab.
Okay, sure.
Sorry, what was the age? I just missed the age.
15 years.
15.
Rose.
115 years old Rose, and she is a diagnosed case of GIA with obesity, respiratory difficulty, and increased frequency of urination, right?
Yes.
Okay. I'll just take a minute, huh?
Yes, sure.
Hello, Dr. Pranab.
Yes, yes. So are you ready?
Yeah.
Then your time starts now, please.
Hello, good morning, Rose. And just like to confirm, is it Rebecca, Rose's mom?
Yeah, I am Rebecca, doctor.
I am Manisha, one of the pediatric registrars in the hospital. I wanted to see you. I got to know that you had some concerns regarding Rose. Is that correct?
Yes, doctor, yes.
Yes. Well, I'm here to gather some information about Rose. Would this be all right to talk to about it? Talk to you about it?
Yes, yes,
Okay.
yes, sure.
Okay. Thank you. Is there anyone else who would be accompanying us?
Actually, you are talking to me and Rose, and my mother is there. Nobody is there apart from me and my mother.
Okay.
You can talk
So
to
are
us.
you okay if I take down some notes?
Yes, sure, please.
Okay. Rose, could you just tell me more about what are your concerns and what brings you to the hospital?
Actually, doctor, I have some problem with my pee. Basically, there's an increase nowadays, the frequency, and apart from this, basically, I have already some pre-existing condition which is called GIA,
Correct.
and there is some difficulty in walking as well. Okay, so I'm taking lots of medicine for that, and top of that, I'm just mm, having some sleep disturbance, and that's why maybe in the school I am just, and nowadays I'm skipping the school. I mean, not interested to go to the school. There's lots of tasks the teachers are giving nowadays. Okay, so basically the school, I'm really not interested to go to the school right now in this situation of this condition.
Oh, I'm so sorry to hear that, Rose, you have to go through this. So, from what I have seen on your previous papers, and you have been diagnosed as juvenile idiopathic arthritis, and I presume that you have been medications. So, this increased frequency of P, since when have you noticed it, Rose?
And this may about last 3 months, doctor.
Okay, okay.
Last 3 months.
And okay, and is there any particular time of the day, or is it through the day, or like even if at night you have a similar complaint?
Yeah, at the night also, that sometimes I'm just waking up for this pee. And
Okay,
my sleep disturbance is there because of pee, as well as
right,
I'm getting so
right.
much of weight and snoring at night, you know.
Okay, okay. So when we say that increase P, have you been increasing your intake of water? Do you think has gone up, or even if you don't drink water, you're just passing a lot of P?
So I'm thirsty most of the time, basically. So I'm taking water as well
Okay.
whenever needed.
Can you just tell me how much of water on an average? A lot of it?
I can't remember. Yeah, a lot of it.
Okay. Okay, fine. You told me about you having problems with your sleeping. So even this problem has been since the same time?
No, this is gradually developing over last 1 year. Basically, I'm getting more of weight and yes.
No, the sleep, sorry. I'm sorry if I was not able to make myself clear. I was referring to your sleep related problem. Has it been since the last 3 months?
Yes, that is developing gradually with the 3 months.
Okay. And have you noticed, or anybody else in your house, Rebecca, or your mom? I would like to ask her, and have you heard Rose snoring at night? Does she have any kind of snoring?
Yes, doctor. She is nowadays, for last 3 months or 6 months. I can't remember. She is snoring whenever she is sleeping.
Okay, and you think that this snoring and the sleep disturbances have been more since the time she has gained weight?
Yeah, after gaining weight, this sleep disturbances is getting worse, you know.
So, Rose, your weight gain has been only since this last few months or 1 year? Is it? It's increased since last 1 year, right?
Last 6 months.
Last 6 months. And can you just tell me what could be the reason for your weight gain? Have you increased your intake, or you feel hungry all the time? What is it like?
Oh no, I'm hungry all the time, doctors. That's the thing. But that may be the reason. I can't tell
Okay.
you exact reason why I'm getting
So for all the above complaints that we have gotten, Rose, are you been on any treatment? Mom, can you tell me more if Rose has been on any treatment?
treatment just only for this, joint problem basically. Yeah, she is receiving some steroid as well, you know.
Right. Okay. And the steroids have been started since when?
Last 7 to 8 months.
Mm-hmm. Can you tell me if you remember the name of the tablet and your dose? Do you have any idea?
I can't remember the dose, doctor. The tablet is called prednisolone.
Okay. And you have been taking them regularly?
Yeah, regularly I'm taking this for my joint pain as well as some difficulty.
Mhm. Okay, and has that made things little better for you?
Yeah, the things are better, but again, I'm getting so much of weight that is sometimes difficult to walk for a long distance.
Right.
Now it's more difficult for me.
I totally understand. I'm so sorry once again, Rose. But have you, once you have been started on steroids, have you monitored with any of your regular doctors regarding the steroids and their side effects?
Uh, Actually, we have missed two of the follow-up because Rose is not feeling well because of this. Every time she is feeling some lethargic because of night time, she is not
Yes.
getting a good sleep.
Right.
Sleep hygiene is not good, so that's why maybe we are planning to go there. But yes, that is the thing.
Okay. Have you been told to have any form of exercise or physiotherapy after your steroids? Have you taken?
Yeah, that is we are doing for these joints only.
Okay, okay. And you have been doing that, right?
Yes.
Okay. So Rose, I would want to know other symptoms. Like, do you have any symptoms like nausea or vomiting anytime?
No, doctor. No such thing.
Okay. What about any time excessive sweating? Have you experienced something like that, or your heart just racing a bit fast? Have you experienced something like that?
No.
No. So your frequent awakenings in the night is only because you have been passing a lot of urine, right?
Yes.
Okay.
Yes.
Okay, fine. Joe, Rose, have you experienced any kind of fever anytime?
No, doctor. No.
No fever. Do you have any pain when you have to pee or poo? Do you have any such complaints?
Sorry. Pain during poo and pee. No.
Yeah. Okay, you've not been having any pain. Okay. All right. Any kind of trauma or any kind of injury that you have had?
No.
Have you had any admission? Have you got admitted previously anytime?
No. For this condition, we are visiting just outdoor basis to my
You've just been doing
one doctor only.
Okay, so please don't mind me asking
9 minutes up. You have only 4 minutes.
Yes, please don't mind me asking these questions to you, Rose. Since you're 15 years old, are you okay if I ask you a few questions, a little personal questions in front of your mom?
Yes, sure.
Okay. Do you have any boyfriend, Rose?
God, doctor, I am so much of depressed as of now because I am getting my worse body image. As you can see, I am getting so much of weight. And after that, how can I am really unable to say anything on this.
Yeah, so sorry. But have you been taking any pills or any kind of drugs? Have you been tried on before?
No, I am so much of sick with this joint problem. On top of that, I never I'm already suffering a lot.
I really understand that, Rose. Have you tried to do anything that could harm you anytime?
Nothing, doctor, nothing.
No. What about your periods, Rose? Are you been getting them regularly?
So that is very much irregular, doctor. So sometimes it's comes during just this time, and sometimes it's.
Okay, I understand. Mom, I would like to know if did you have any problems or during Rose's delivery or any time after delivery?
No, nothing.
Okay, and how has Rose been in school and development-wise? Has she been okay?
And that is the main concern. So you should ask this question earlier, doctor. She is not willing to go to the school because of this weight gain and some joint problem. Maybe I don't know why she is not going.
Have you spoken to anybody regarding this?
No, I have already spoken to our school authority, but she is having some lethargy all the time because of sleepiness in the daytime.
Okay, we'll try and see if we can have Rose speak to our psychologist. Maybe that would help her. And I wanted to know, so she's been missed out on a lot on the school part, is it?
Sorry?
Has she missed out on a lot of school?
She is totally nowadays unable to go. I mean, not willing to go to the last 3 months. She is not going to the school. No, doctor, I am so much of angry with that.
I can understand.
It's very difficult.
Yeah, how many
I
members
really don't know why.
Rebecca?
How many?
Members in the family?
It's me, my husband, and my elder son. I mean, yes, son is fine.
And anybody else with this condition?
No, doctor, no.
Okay. Does Rose have any kind of allergies or anybody smoking in the house?
Sorry, any?
Anybody smoking in the house or any allergies which Rose has?
No allergy, no smoking.
Okay. Has she completed her jabs?
Okay, so before the diagnosis, everything was given, but whenever the doctor started this steroid, they said no live vaccines.
Okay. So Rebecca, I'm sure it must have been very difficult for you. Has it caused a lot of a social, like a difficulty on you? Have you been able to cope up with it? How are you coping up with it?
Yes, doctor, I'm very much depressed. She's crying now. She's crying basically. Okay, because I'm unable to walk properly, and lots of joint pain is there, and on top of that, I'm gaining weight, and my body image is gradually, just everybody making fun of me at school, and I have also don't have any good sleep at night, and every time I'm just like sleepy. So I really don't want to go to the school, doctor.
Yes, I am sure, Rose, this is a lot of concern for you and it's understandable. Let me reassure you, Rose, that we are here to help you, and maybe from whatever your history I have got it, let's see what best we can do for you, okay?
Okay, doctor.
Okay, thank you so much. Is there anything else that you feel that you needed to tell
14
me?
up, right? No, 14 minutes up. You want a few seconds more?
No, I think just wanted to have some past history. I think immunization history is done, vaccination history is done. I don't know if there's anything else. She is not followed. Okay, Rose, I would just like to know, have you, for this weight gain, have you been tested for any of the side effects? Oh, okay, I asked her already. Okay, the side effects of steroids.
Okay, I think you covered most of the area. You can present.
Yeah. Okay, so today I had the opportunity to speak to 15-year-old Rose and her mom Rebecca, and with the main complaints of she's already a diagnosed case of JIA, presently came with respiratory distress, snoring, polyuria, and polydipsia, and excessive weight gain. From her history, I could gather that she's probably suffering from, she's probably developed side effects related to steroid for which she has failed to follow up. And I would also want to rule out if she has developed type 1 diabetes mellitus, or it could be secondary to excessive steroids as well. So I would like to do her more examination, and I would like to go to her previous papers and also check her medication and the medication compliance and the dosage which she has been taking.
What is your most likely diagnosis? What are the diseases you are thinking for this condition?
So for me, the first thing that since she is being, this could be a side effects. Firstly, it could be a side effects of steroids, which she has been taking for 7 to 8 months, for which she has missed her 2 appointments in the previous set. So probably it could be the side effects of steroids, or probably there could be a secondary complication, or probably she's developed type 1 diabetes as a part of JIA.
So type 1 diabetes, there will be weight loss, not weight gain.
Oh, sorry, type 2. Yeah, I'm sorry. Or it could be, type 2. But, and she's also got obstructive sleep apnea, secondary to obesity.
Okay. So what exactly the cause of obesity?
So like I said, it could be probably secondary to steroids. I'm not sure about maturity onset.
So steroid induced obesity, what may be the other name of this condition?
Cushing's.
So have you checked the features of Cushing's during your history taking? What are the other features of Cushing?
I could have asked for her excessive striae or purple striae on her abdomen or her back, or like an excessive collection of fat, or on the nape of the neck. I could have checked for any facial puffiness, or
Rounded face, basically.
rounded face, or acne on the face.
Yes. Thinning of the hair.
Excessive hair, yeah, hirsutism. Yeah.
And yes, these are the basically features which we can ask to the mother.
Mm-hmm.
And that will help us to keep the diagnosis more appropriately. Like this child is secondary Cushing's due to drug-induced Cushing, steroid-induced Cushing syndrome. Okay. Rest of the part you probed every area, mostly covered every area. But if you are not coming to the point, then that will be a little difficult. Okay.
Steroids, but yeah, I should have thought. Yeah.
Steroid-induced
Anything else that I missed? The other question. Anything else that I missed?
No. I will take the opinion of the other people, but before that, definitely you need to ask the fat distribution. Okay, so child is getting obese. So if we are dealing with obesity, so you need to format our questionnaire just like features. Features means what is physical features that will help us to come to a conclusion, right? And then onset, just like with the features I have just discussed. Okay, these features, number 1. Number 2 is just when this has started, that you just elaborated during your history taking, right? And the puberty you touched very well. Puberty is also important. And if the patient is obese, you need to check. So this is clear-cut drug-induced, or this is steroid-induced. But if this drug history is not there, then you need to ask the history of the family history, basically. Sometimes parents are basically obese. Okay. So not only that, this familial. And for that reason, you need to ask for height, weight, according to the growth chart. I mean, some of the parent even know. Okay, the previous doctor or the GP saying that a child is having apparently just not growing according to the height of the parent. Basically, there will be short height if this is endocrinal cause. Okay, and after that, school performance is the must. School performance is must. Why? Why? Can anybody suggest why I'm telling that school performance we need to ask in obesity?
Because of obstructive sleep apnea, there could be increased sleepiness in the morning and decreased concentration.
No. Just definitely, but you need to think in a broader view. Okay, just like not that. If the child
Hypothyroidism.
is, yes, definitely. So I'm just telling you. Suppose the child, I have given you more detailed history during the stem. I mean, during the stem, I have given lots of information. The child is having this arthritis. For this reason, the child is already getting some medicine that is drug induced. And if suppose this history was not there, the child is complaining of recent weight gain or maybe over the period of 6 months or 1 year, definitely we need to ask about the school performance. Why? Because some syndrome with obesity may come with decreased IQ, low IQ, and some of the obesity may present with the normal IQ. So the school performance, maybe some of the children are attending some special school. Just like Turner, most of the time is normal, but sometimes then there may be low IQ, Noonan syndrome, there may be weight gain as well as Williams syndrome, weight gain. So all this syndrome with low IQ maybe a cause of may present with the obesity as well. Okay.
Yeah, Dr. Pranab, can I just say something? To add in the history, hello?
Yeah.
To add in the history, like for ruling out syndrome, maybe we could ask, has she been obese since birth or only recently?
No, but she
I
said
just given some, just mean I have given some misinformation. That is, if this child is syndrome with low IQ, that maybe that is Down syndrome possible, Prader-Willi as well as Lawrence and Barber-Biddle. Okay, so I was
I
just
think
thinking
Dr.
little
Pranav gave me
differently.
the history. Yeah, he gave me the history that it's only since last few months and 1 year. He said
Yeah,
that.
but we don't know the baseline weight, right? Maybe she was already a little overweight only and like, picked up over the past 6 months. I just meant to say that.
Don't compare with this one. Basically, this is a typical case of drug injury that is gradually developing. When this medicine has been changed with steroid, after that gradually this obesity has developed. But if the child is already obese for a long time, that maybe short with low IQ or normal IQ. That's why this school performance very much is important. And if that's why growth parameter also important during a history taking, we can ask whether do you think that the child is growing well according to your and your husband's height. As GP anything mentioned you whenever you attend the GP visit. So at that time, if the child is growing well, tall or simple obesity may be one of the cause. Okay, sometimes is just only obesity. And if this is some syndromic with low IQ, that time I just mentioned this may present with this obesity. And if this is endocrinal cause, then growth hormone deficiency, Cushing, just to mention, Cushing may be not only drug induced, there may be just central and peripheral as well, according to the etiology. And sometimes pseudoparathyroidism, hypoparathyroidism, basically, hypoparathyroidism and hypoparathyroidism, all of these are causes. So according to that, we need to ask the questions. Okay. So that is the reason. This rest of the format, I think you mentioned, and this child, there was a lot of information. And if this is pushing, definitely, you need to ask for the blood pressure. And even the GP just measured your blood pressure during your CVS, CVS assessment, giving the relevant systemic history. you can add on. The blood pressure is very important. And yeah, menstrual history, ask. I said there was irregular. Yes, I remember that. Okay. Now what? Okay, so Dr. Manisha, are you there?
Yes, I'm there.
So, what are the investigation you want to do for this child quickly?
So I would like to start with an examination, obviously, take her centiles, plot her height, weight, and do her BMI to check what is.
BMI, right.
And I would also like to check her vitals, especially her blood pressure, her pulse, and her respiratory rate. I would like to do a thorough examination and look for signs which could be suggestive of Cushing's. And I would like to proceed with investigations, including full blood count for any infection, to see her blood sugar levels, her serum electrolytes, when she has polyuria and polydipsia. So also I would like to do her lung function test and kidney function test. I would like to ask her details about the steroids which she has been taking. I would like to liaise with the ophthalmologist and look for any signs which could have like a glaucoma secondary to excessive steroids. I would like to liaise with the endocrinologist.
Glaucoma, rather than you can say cataract. Steroid cataract is more common. And if you are thinking GIA, wait. Yeah, it's okay. So if you are thinking GIA, because background information is GIA, right? So there may be some eye involvement. I have not mentioned which type of GIA. So uveitis is maybe possible, one of the reasons. And second reason is, as you said, cataract, right?
Cataract, yes, right.
Okay,
so
continue.
With the I would like to speak with my consultant and take a special opinion from the rheumatologist regarding her GIA and the involvement of the other systems. And I would like to also do a psychological counseling for Rose, since she seems to be having issues with school and her body image. So, I would also like to liaise with the dietitian and maybe a dietitian to for her weight control and her exercise. Yeah.
Okay.
Like ophthalmologist. Yeah.
So how you will manage this child?
So once I have the investigations and I have informed my consultant, I would like to liaise with the endocrinologist regarding and the rheumatologist regarding the dosage of steroids. If she has, since she has developed side effects related to excessive steroids, I would like to consult and decide if we can go to other disease modifying drugs for Rose. Which probably could help her relieve her of her side effects. And also I can see that she is not being able to go to school because of issues with her body image. So I would like to liaise with the school authorities regarding her condition and her medications. Like I said, I would like to check for other side effects and see if we can we can change the disease the medications. Yeah.
Okay. So you want to involve the ENT doctor?
Yeah, I would like to also do an ENT checkup for and also do her polysomnography, since she has complaints of obstructive sleep apnea, and her dietitian and exercise consultant to lose weight and probably decrease the dose of steroids after consulting with the endocrinologist, and look for other disease modifying anti-rheumatologic drugs for her.
Family therapy, have you heard about the family-based therapy? family therapy.
Yeah.
You have to counsel all the family members because sometimes with obesity, the other people will have if the child is so much of depressed or having some disability, just like this. Sometimes family therapy is also. You can involve a social care worker. They will arrange the disability allowance as well as some in view of arthritis. Okay. Some holidays and some finance if needed finance. Okay. So according to the configuration that is given in the guidelines, so that's very easy. If you read, then that will be very easy. Obesity related complications and management. Okay. So okay, guys. So any other feedback then?
I just wanted to add, because of this obesity, maybe it could be a cause also. She already mentioned
Which
she's
one?
taking a lot of eating. Maybe we could ask about sedentary lifestyle also, because her knee pain could be causing her to do the physiotherapy or the exercise lesser.
Definitely. So what is the cause of the here? So first thing, sedentary lifestyle because the child is unable to work. Second thing, she is taking steroid and that will increase the appetite as well.
So, yeah,
Right?
yeah, yeah.
So
And also
we were
involve the
taking a
cardiologist. Yeah.
yeah, cardiologist for any cardiac complications, right?
Yeah, for
So that is
OSA,
given in
for
the
pulmonary.
guideline. Yeah,
Yeah.
definitely. That is given in the guideline. We can have a look and that will be very easy, right?
Yeah. Nice. Yeah, done.
Okay, any other feedback, guys? Okay,
Will I
if
get
no,
a pass?
then we'll.
Will I get a pass?
I am no one to decide this one actually. I am also learning from you people. Okay, so this is actually I am basically reading. After that, just making the scenario and discussing those. That's